Hello everyone, I am Dr. A M Thirugnanam, Senior Interventional Cardiologist. Today I am going to give more information about the controversial topic, the debate on particular cardiovascular medicine, aspirin consumption. Is it universally beneficial? Who should take it? And what do the latest ACC, AHA, ESC, and the Canadian Society of Cardiology guidelines tells us? Let us dive into the topic. Aspirin or salicylic acid has been used for over a century. Its antiplatelet effects reduces blood clot formation, a key mechanism in heart attacks and strokes. For decades, aspirin was recommended broadly for cardiovascular prevention. But over the last 15 years, major clinical trials and guidelines updates have reshaped clinical practice dramatically. Today, I am going to cover what aspirin does biologically, key evidences, supports, and evidence from major clinical trials, current guidelines, and benefits and risk of, and practical advice for patients and clinicians. This is very important. Let us see how the aspirin works. Aspirin irreversibly inhibits cyclooxygenase 1, COX1 in platelets, preventing formation of thromboxane A2, a chemical that promotes platelet aggregation. Because platelets cannot regenerate COX1, this effect lasts for platelets lifespan roughly 7 to 10 days. At low doses, 75 to 100 milligram aspirin exerts antiplatelet activity. At higher doses, it has anti inflammatory effects, but with increased bleeding risk. And we are using aspirin in primary and secondary prevention of heart disease or major primary neurovascular disease and peripheral vascular disease. Before we proceed, it is important to distinguish secondary prevention, where the use is compulsive indication. Patients who already have established cardiovascular disease, prior heart attack, stroke, coronary artery disease, peripheral artery disease. In those cases, patient has to continue aspirin for the particular period of time. In primary prevention, individuals without prior cardiovascular events but with risk factors like diabetes, hypertension, or high cholesterol, guidelines treat these differently. Let us look into the evidence. Evidence in secondary prevention. In patients with the established atherosclerotic cardiovascular disease, aspirin reduces recurrent heart attacks and strokes. Key evidence. Clinical trials in 1980s and 1990s showed 30% reduction in recurrent events. Meta-analysis consistently support aspirin as standard of care in secondary prevention unless contraindicated. That's very important. What the guidelines, consensus of guidelines? American College of Cardiology, American Heart Association, European Society of Cardiology, Canadian Cardiac Society, all strongly recommends lifelong low dose aspirin in secondary prevention, bearing major bleeding risk. This is one instance where aspirin benefits clearly outweigh the risks, especially in patients with prior MI, prior PCI with stenting, established vascular disease, and post CABG status, bypass status. And what is the use of primary prevention? Because people they are talking a lot of videos coming into the social media. Taking aspirin will prevent the heart attack forever. Let's dive into this topic particularly. This is where the controversy exists exactly. Large trials and what they found over the past decade, several major trials have reshaped our understanding. ASPREE trial 2018. In healthy older adults, aspirin did not significantly reduce cardiovascular events but increased major bleeding, especially gastrointestinal bleeding. Arrive trial in the year 2018. This trial in moderate risk individuals, aspirin did not significantly reduce major cardiovascular events and again carried bleeding risk. Ascent trial 2018, ASCEND. In patients with diabetes, there is no prior events. Aspirin reduced vascular events modestly but increased major bleeding. That's also trial conducted in the year 2018. The key conclusion is very important. In low to moderate risk patients, adults without prior events, the benefits are small and often offset by bleeding risk. Current guidelines explained American College of Cardiology, American Heart Association, European Society of Cardiology, Canadian Cardiovascular Society. They are all recommending strong recommendation in secondary prevention of low dose aspirin. In the primary prevention, not routinely recommended for adults over 60 years. And in general, it's reserved for selective high risk patients aged between 40 to 70 with low bleeding risk. Bleeding risk is very important. According to European Society of Cardiology and echoes of ACC and AHE. So European Society of Cardiology also accepting the same what has been a guideline by ACC and AHE. No routine use of aspirin for primary prevention in most patients due to bleeding risk outweighing benefit. Canadian Cardiovascular Society also advises against routine use in primary prevention, particularly for older adults. Across major guidelines, the pendulum has shifted completely. Routine lifelong aspirin for primary prevention is no longer standard of care. If you weigh the risk and benefits, the reduced risk of recurrent heart attack and ischemic strokes in secondary prevention, really obvious. Almost 30% reduction. Potential plaque stabilization and antithrombotic effects. These 2 points are very valid points. In case of risk, if you want to see the risk, major bleeding, gastrointestinal and intracranial bleeding, it's very common with the aspirin above the age 70 years. Increased risk with age, prior ulcers, concomitant anticoagulants, NSAID use, alcohol use, and H. pylori infection can cause GI bleeding. Clinical takeaway, what you can take from these studies and observations and current guidelines. Their net benefit depends on individual risk profiles. Aspirin may benefit a high risk primary prevention, patient with a low bleeding risk, but not for everyone. Don't forget this. Aspirin is not for everyone for primary prevention. Clinical practice, who should take aspirin? That's very important. Recommended aspirin if history of MI, myocardial infarction, primary percutaneous intervention before those who had undergone angioplasty with stenting, established coronary disease, cerebrovascular disease, or peripheral vascular disease. High risk patients with a low bleeding risk after shared decision making is very important. Decision making is a very crucial role in recommending aspirin in secondary prevention. Avoid or consider if age is more than 70 without prior events. History of significant bleeding, we need to think again. Concurrent anticoagulants, uncontrolled hypertension, shared decision making is very important. This is essential. Discuss individual cardiovascular and bleeding risk using validated tools and patient preferences. So, hereafter, no one can freely take aspirin to prevent the heart attack. We need to take expert opinion. Without expert opinion, don't take as a self-medication to prevent the heart attack. In summary, lifelong low-dose aspirin is standard and beneficial secondary prevention. But for primary prevention, recent evidence and major international guidelines recommend a selective, individualized approach due to bleeding risk. Before starting or stopping aspirin, always consult your cardiologist, not on your own. Thank you for watching this video. If you found this valuable, like and share, subscribe for more evidence-based cardiovascular insights. Don't forget, I will meet you in the next video. Until then, bye-bye. Take care. Take care of your heart, take care of your family, and take care of your relatives and friend circle. Everybody's heart is very important to me. So, take care of you. Goodbye. Thank you.